meeting.
Are we able to hear you? Hello, our dear listeners. Please confirm that you can hear me well. Thank you. So just
Recording in progress.
okay.
What is this?
No, it's okay.
Yeah.
I'm presenting OM, 45-year-old male, newly diagnosed ISS at naive with a 5-day history of severe front headache associated with neck pain and low-grade fevers, irritability, and he also had a productive cough with white sputum, chest pain with mild difficulty in breathing, and
Someone has again got me. She doesn't have hand me on the wall. Slides. They're not there. They're not there.
sorry, our dear listeners, it's just a technical glitch, and we're happy that it is now sorted. Let me start off with the case presentation. I'm presenting OM, 45-year-old male, newly diagnosed ISS, was referred in with a 5-day history of severe front headache associated with neck pain and low-grade fevers. He was irritable and also had a productive cough with white sputum. He also had chest pain with mild difficulty in breathing, and notably, he had also severe weight loss. In the primary survey, our patient could talk, so that informed us that our airway was patent, Notably, he had mild respiratory distress with a respiratory rate of 26 breaths per minute, an SpO2 of 85% on room air. On examination, he had a bilateral chest rise and expansion, equal and bilateral air entry. Normal breakdowns on auscultation. He had warm peripheries with a cup refill time of less than 3 seconds. Had a pulse rate of 110 beats per minute, slightly tachycardic, and had a blood pressure of 149 out of 70. Was disoriented. GCS 10 out of 10. Pupils of equal and reactive to meds. No focal neurological deficit. Blood sugar is 9.6 milligrams. Exposure, the ant was severely wasted. Prior that date. Exposure was severely wasted. Also February, the temperature 38.0, some dehydration. Remember that. Yes.
Because speak. Okay. So we're going to have our poll, our first poll, and we are saying from the history and the primary survey. What is the most eminent emergencies in this patient? So we have options in our first question, which is from the history and primary survey. What is the most eminent emergency in this patient? It is single choice, and the first one is dehydration and electrolyte imbalance. So colleagues, you can be responding to the poll question. The second one is hypoxia and severe respiratory distress. The third one is hypoglycemia and hypotension. And lastly is airway obstruction and tension pneumothorax. So we can be responding to the poll question in a few minutes and see what we have. Okay, I think we can proceed to the next part.
Okay, thank you for those responses. Let's continue with our presentation and see what were the emergency conditions in this patient. You can see that this patient was hypoxic with an SpO2 of 85% on room air. So what you're worried about this patient, if not attended to, this patient can progress and go into a hypoxic cardiac arrest. Our patient was also in respiratory distress with a respiratory rate of 26 breaths per minute. If not attended to, this also predisposes this patient to respiratory failure. Our patient also had altered mentation with a GCS of 13 out of 15. So our biggest worry in patients who have altered mentation at this time, though our biggest worry here is the airway in case the mentation continues to drop. So we shall be monitoring that airway.
Okay, so we go to our second poll from the day, and we're saying, based on the above information, what are your management options for this patient? It's a single choice question. And our first option is oral rehydration and monitoring, high flow oxygen and intratracheal intubation, intravenous paracetamol 1 gram and oxygen therapy, and schedule outpatient follow-up in a week. So we can be filling in our answers and respond to the poll. Please keep the responses coming, and as we proceed, keep them coming. Okay, thank you so much for those responses. I think we can proceed.
So let's look at what was done at that time when okay. Kindly accept our apologies. It's just an issue of electricity. So for this patient, the emergency conditions that were picked out is that the patient was hypoxic. So at that time, we decided to give our patient oxygen by using nasal prongs, and was given 5 liters. Still, our patient was in respiratory distress, and hypoxia was the driving factor for this distress. So the intervention was still oxygen therapy, and altered mentation with the airway at risk, though was still patent. We opted to monitor and maintain airway patterns in case using adjuncts in case there is need at any time T. So other things that were done to stabilize this patient was propped up, and still oxygen therapy came in handy, and blood samples were taken off for investigations. In our sample history, a patient presented with a severe frontal headache for 5 days that was associated with neck pain. No photophobia, no loss of consciousness, and no focal neurological deficits. He also had a cough of 3 weeks that was productive in nature, white sputum, and it was associated with a mild chest pain and difficulty in breathing, with a respiratory rate of 26 breaths per minute. He reported no history of drug or food allergies. And from the referral site, he came in when he had been started on medication, IV fluconazole, 200 milligrams twice a day, oral cotrimoxazole, 960 milligrams once a day, IV ceftriaxone, and was also on IV metronidazole. The past medical history was a newly diagnosed ISS from the referring facility, and this was his index admission, and that the diagnosis of HIV was made at the time of admission from the referring facility. He was ART naive, and he had no history of DM or hypertension. His last oral intake was not captured, and what led him to going to the hospital at that time was a severe frontal headache, the neck pain, and a productive cough. And from that site, that's where he ended up being diagnosed with HIV and was further sent to Mulago for further investigations and management. In our head-to-toe examination, we looked out for the relevant positives and the relevant negatives. So this is a patient who came in very cachectic, severely wasted, had a low-grade fever of 38.0 degrees Celsius, neck pain, also had mucorigidity with a positive Canning sign. He had a cervical lymphadenopathy and was tachypnic. However, our patient had no oral or skin thrush, and he had equal air entry with vesicular breath sounds. He had no splenomegaly on abdominal examination, no hepatomegaly, and notably, he also did not have any peripheral edema. He had no focal neurological deficits and a negative Brudzinski sign, and no peripheral neuropathies. So at that time, we asked ourselves, what are the possible differentials to look out for in this patient? We grouped our differentials. Under the infectious group, our differentials included meningitis, which can be either bacterial or fungal, encephalitis, sepsis, or pneumonia. As we all know that all these can alter the mentation of our patient. Electrolyte imbalance under the metabolic group with hypo or hyperglycemia, uremic encephalopathy, hypo or hyperkalemia, hepatic encephalopathy, and thiamine deficiency. Under the iatrogenic group, we thought of drugs especially the fact that our patient was complaining of severe frontal headaches, it's possible that he could have been started on opioids. And either way, or maybe they could have given him some benzos because he was very irritable, and could be the reason as to why his mentation was dropping. Under the neoplastic group, we looked at space occupying lesions, for example, gliomas, meningiomas, and mets to the brain from other organs.
Thank you, Dr. Secretary. Next is our poll number 3. And we are asking that what are the CSF findings in bacterial meningitis? And we have options. This is here, which are the first one being tablet glucose of less than 2.2 moles per liter, a white blood cell count of greater than 1,000 in a microliter, and the PMNS greater than 80%. The next one is clear normal glucose with a white cell count less than 1,000 in a microliter with PMNS greater than 50%. The third one is clear glucose greater than 2.2 millimoles per liter, white cell count greater than 1,000 in a microliter, and PMNS greater than 50%. And lastly, we have tablet with a glucose of less than 2.2 millimoles per liter, white cell count greater than 1,000 in a microliter with an PMNS greater than 50 lymphocytes. So keep your responses coming in, please. Keep your responses coming, please. And PMNS was standing for polyphonuclear cells. Keep them coming, please. Thank you so much. I think we can continue to the next chapter.
Thank you for those responses. So now, let's see the results that came through for our patient. Responding. Thank you. So, our dear listeners, these were the investigations that were ordered for this patient. And A complete blood count was done with an HB of 16.5, WBC of 4.32, which was normal, lymphocyte count of 0.51, slightly low, and the granulocytes or neutrophils were 3.38, which was normal, with a platelet of 216. A CD4 was also done, and he had less than 200 copies of the CD4 cell. TB urine lamp was done, and the GeneXpert was also done. The urine lamp was negative, and MTB was not detected on GeneXpert. A serum CRAG was also ordered, which returned positive. LFTs were normal, RFTs were grossly normal, and the CSF analysis was done. A volume of 10 mils was picked with an opening pressure of 40 centimeters of water and a closing pressure of 25 centimeters of water. The CSF was clear with a lactate of 2.5 millimoles, glucose of 35 milligrams per deciliter. CSF CRAG was positive. Total protein of 35 milligrams per deciliter with a WBC count of 35 cells. A BS for malaria was ordered under urinalysis, and no malaria parasites were seen, and the urinalysis was grossly normal. So going back to the question that was asked, you can be able to differentiate the two, that in this side, the CSF was clear. The other side, the CSF, I saw most of you choosing the CSF being turbid. Opening pressures are raised in both cases, but we expect them to be much higher in the bacterial meningitis. Instead of doing the CSF CRAG for the other side, we do the gram staining, and we can also do a culture and sensitivity to look for the causative organism. Glucose is decreased in both, but it's markedly decreased in the bacterial infections. And WBC count is elevated in both, but markedly elevated in the bacterial type of meningitis. So I think with that, you can be able to look through and be able to see what was the most correct answer at that time. Under investigations that were done, imaging was one of them, and a chest X-ray was done. As you can see, it is in the PA view with the trachea midline, and the mediastinum is not widened. We have a normal cardiac silhouette, but notably are the mild diffuse hazy opacifications throughout both lung fields, which really show increased interstitial lung markings. Yeah, suggestive of a type of pneumonia. Yes. So you can see that for our case, our patient TB, though not detected, it's still a bit of subjective. It's still subject to a debate. But in this case, we do not have cavitations that are really suggestive of TB. Notably, brain CT scan was not done, though it was ordered, and an abdominal ultrasound scan was also ordered, but not done. Basically, for the brain CT, we want to be able to rule out all other possible causes of altered mentation in our patients, and also to guide us on how severe the edema is in our patient, the brain edema. So our diagnosis, we zeroed down on this diagnosis of a 45-year-old male, newly diagnosed HIV with cryptococcal meningitis in view of the positive CSF and serum CRAG with the presentation of a severe frontal headache, neck pain, and a positive Canning sign with a very low CD4 cell count. So that was the basis on which we based to come up with this diagnosis, also looking at the investigations that were done at that time. And our second diagnosis was pneumocystis jirovecii pneumonia. In view of the presentation of the patient being very immunocompromised, coming in with a cough that is non-bloody, and the chest X-ray really doesn't have any kind of like cavitations or miliary presentation. And we zeroed down on the diagnosis of pneumocystis jirovecii pneumonia for this patient.
Okay. Okay, we're on to our last poll number 4. And the question goes like this. What is the definitive management option for this patient? It's not. Okay. So our poll is, what is the definitive management option for this patient? And it's a single choice question. Number 1 is intravenous liposomal amphotericin, 1 milligram once a day, with flucytosine, 100 milligrams once a day for 1 week, followed by fluconazole, 1,200 milligrams, 24 hours. That's once a day for 1 week. Second option is intravenous flucytosine, 100 milligrams per kilogram once a day, plus fluconazole, 1,000 milligrams, 1,200 milligrams once a day for 2 weeks. The third option is intravenous flucytosine, 100 milligrams once a day, plus fluconazole, 1,200 milligrams once a day for 2 weeks. And lastly, single high dose liposomal amphotericin B, 10 milligrams per kg, followed by, for 2 weeks, followed by flucytosine, 100 milligrams per kg once a day, and fluconazole, 1,200 milligrams once a day. Please keep those responses coming. Let's fill in the poll. Let's see what you have. What are your thoughts? We have been going through the case together.
Recording in progress. We're almost there. Let's keep the responses coming.
Okay, thanks for their responses. Let's continue, please, Doctor.
Thank you very much for those very good responses. So let's straight away look at our management options for this patient. So in the management of this patient, we have the supportive management, where we put our patient on oxygen therapy by nasal prongs. Patient was propped up. We'll manage his pain. The fact that one of his major complaints was the severe frontal headache, which was managed with IV paracetamol. And we also gave IV fluids, and we kept monitoring the urine output for this patient. And remember, it's also important to give enough IV fluids to your patient as you're preparing them for drugs like amphotericin B. So this is the specific management with a diagnosis of cryptococcal meningitis. We gave a single high dose of liposomal amphotericin B, 10 milligrams per kg on day 1. And that was followed by tabs of fluconazole, 1,200 milligrams once a day for 2 weeks. Tabs of flucytosine, 25 milligrams per kg per day into 4 divided doses for 2 weeks. And we also did weekly LPs. An LP was done at admission, day 7 and day 14. The significance of these LPs, in as much as you're picking a sample for analysis, they're also therapeutic. And specifically for this patient, this is a patient who would have benefited from daily and the ICP in this patient, as we all know that according to the Kelly, the Monro-Kelly doctrine, three things. That's the scalp vault comprises of 3 things. That's the brain, the CSF, and the blood. So any change in the volume of any of those 3 affects the pressures within the vault. So in this case, if you have an edematous brain, that means it's increasing the volume of the contents within the brain. And this raises the intracranial pressure. And also the fungal meningitis has also an obstructive mechanism of increasing the CSF and the intracranial pressures. So it's important that we do these serial lumbar punctures so that we can reduce on the intracranial pressure, which is one of the key players in the morbidity and mortality of our patients. The other diagnosis of pneumocystis jirovecii pneumonia, we started our patient on high-dose cotrimoxazole, 1,920 milligrams, TDS for 3 weeks, and was also started on prednisolone, 40 milligrams twice a day for 5 weeks. You realize that there is a controversy of using steroids in a patient in whom we have diagnosed cryptococcal meningitis, but now we are going on to use steroids. But in this case, you weigh the risk-benefit ratio for the patient. If a patient is desaturating, and we all know that steroids are a mainstay in the management of PJP, it is upon you as a doctor to give this drug and then monitor how your patient responds. You can discontinue or continue the drug depending on the response of your patient. So we opted to start the prednisolone in this patient because we were worried that the hypoxia due to PJP was going to kill our patient faster. So, and the patient responded well. The patient was disposed of to the infectious disease ward, and a follow-up plan was drawn from there with a consolidation phase of 3 weeks and a maintenance phase of 6 to 12 months as listed below. Thank you.
Thank you so much, Dr. Paul. We are progressing with our program of today. Next is we are going to look at pre-hospital care of a patient with altered mental status, which is going to be presented by none other than Mr. Sugarimbo as he introduced himself. You're welcome, Mr. Raymond.
Hey. Thank you so much for the first presentation. I'll proceed with the pre-hospital approach to this patient who has altered mentation. So my approach is going to be for all the altered mental status, not being specific on the case. However, we shall be closing it in with a case. When we get to this patient there and then, we shall dive into our assessment, which starts with the scene safety, and we have to ensure that where our patient is, they are safe. For example, if you move outside and they are not in the hospital, we would want to know whether we have any clues on what would have caused the altered mentation. For example, we might have drug bottles that are around, anything that has been used, for example, syringes. So you make sure that you capture all that. Then make sure you have your personal protective equipment on, because you need to protect yourself first. Like you see that gentleman there, he's already putting on their gloves. Possibly you could even have a mask on in case of any chemicals. Like I said earlier, please look for any clues like the empty bottles, pills, in case of any drug overdoses. Look for any clues to talk about trauma. If someone is vomiting, look for anything that is communicating around that area. Then you are supposed to actually do a quick assessment of your level of consciousness. And this is done by calling your patients very fast to find out their level of response, which is used following the AVPU, alertness or response to voice, pain, and lastly being unresponsive. After doing that, we move on to our primary assessment, which always is done following the acronym of ABCDE. With the pre-hospital, we actually follow that so much. And as earlier presented by my colleague, we still follow the ABCDE. We start by airway. And in the airway, we position this patient in accordance to the level of consciousness. In this case that we have been having, our patient is having a patent airway, so we just prop them up. But in case our patient assumes the other levels, V, P, and U, we shall want to position them in an appropriate way for us to continue with the assessment. So we have to check our airway by looking through the mouth, okay? And in case there is any obstruction, say vomitus, blood, foreign bodies, please go ahead and follow the maneuvers that we have just mentioned, the suctioning, head tilt, chin lift in case there is no trauma, and a jaw thrust for trauma suspects to clear off any obstruction so that the airway is patent. And you could possibly go ahead and use some adjuncts, for example, the oropharyngeal airway. And this is usually only used in patients who are unconscious, who do not have a gag reflex. If someone has a gag reflex, then you could probably think of using a nasopharyngeal airway in the need to maintain the airway. Proceed to the breathing, and we usually do this by following the look, listen, and feel, where we have to look for the chest rise. I'm now having my patient lying in supine position because I want to assess. I'm assuming the patient is now unconscious. However, even if they are not unconscious, we have to look for some things in the breathing. We want to look for the chest rise. Is it symmetrical? Do we have respiratory rate? You want to know how the respiratory rate is. You want to know if there is any use of accessory muscles. Go ahead and auscultate for any abnormal sounds and manage accordingly. Please check for the oxygen saturation on room air, okay? Because we want to get a baseline of what we are going to manage. And depending on what you have actually done, please go ahead and give the high flow oxygen for a patient whose oxygen saturation is 85. I would start off with high flow oxygen and with a mask. But please be considerate. If someone's having hyperventilation, please go ahead and support them with a back valve mask. Go ahead and proceed to the saturation. The saturation, we have to check our skin color because it communicates. If the color change, if there's color change, we want to know why. Probably they have had a color change, probably they've been bleeding, maybe they are in shock. We want to check the cup refill time, which has to be less than 3 seconds. And if it is more, then it prompts you to do something, okay? Then we have to check our pulse rate. Is it regular? Is it irregular? Is it there, not there? You understand? And then we have to go ahead and do our blood pressure because they are the key factors we look for in response to shock. And if we have any bleeding, please control that bleed, okay? Then I would suggest we go ahead and get an IV access if this person doesn't have one, because we are preparing for the worst, okay? In case someone is maybe more than 3, the pulse rate, probably someone is tachycardic, like our patient was a bit tachycardic. The blood pressure communicating about shock, please go ahead and give IV fluids. We always prefer giving crystalloids, and we do this in case our patient is either hypotensive or dehydrated. We proceed and do a disability check. This is a quick neurologic check to see how our brain is actually functioning. Okay, so we go ahead and assess the level of consciousness. If you did an AVPU earlier, you could possibly go ahead and reassess it, or if possible, you could expound it to a Glasgow Coma scale and know the level of your patient at that moment. Then you have to check for the pupils to see their reaction. We have to know the normal size. Is it reacting to light, not reacting? Are they equally reacting, or one of them is reacting? All those give us a hint on what is actually happening to the brain. Then we have to take a quick random blood sugar. Possibly if you had put an IV access, you could actually take an RBS then. But if not, then you could probably do it at this level where you are supposed to check and see whether your patient is hypoglycemic or hyperglycemic. And in case of any irrelevance, you have to actually manage. We are saying you have to proceed still and manage any seizures in case they are noted. Please protect the patient by administering either midazolam or diazepam, okay? The dosage for diazepam we could give in an adult, we could use 5 milligrams to 10, which is supposed to be given as a slow bolus. Then we could, in case of any opioid overdose, we could give an antidote in case we have it in the ambulance. But if we do not have it, we manage the other risk factors, the other parameters, and then we plan on our transfer. We proceed and move to the exposure. Here we have to expose our patient and we look for any hidden injuries. Patients are always clothed, and we need to look at their body to find out any marks, any rashes, any medical tags, signs of dehydration, muscle wastage. For example, in our patient that we have just presented earlier, this patient was massively wasted. Then we have to check for the temperature, and we have to manage hypothermia or the hyperthermia that this patient might be having. Possibly our patient could be having fever, so we have to manage. Still in the sample history like they did earlier, so we have to take the sample history, and here it gives us all the information that we might need to know about our patient. We always start with the signs and symptoms, find out any symptoms, the sign the patient presented with, and tailor it to the altered mentation. For example, was there any vomiting, difficulty in breathing? Because difficulty in breathing with altered mentation could communicate something happening to the brain because of reduced oxygen. Is there neck pain and stiffness? It would also communicate to maybe infections like meningitis that are manifesting in. Is there any fever? Okay. Are we having a headache, which could communicate to maybe a stroke? Okay. It will lead us to maybe looking for a stroke. Do we have any history of or do we have any allergies? Is this person exposed previously to any allergen? And if they have any, we need to find out which allergen that would be. Then we want to also look at the medications these people are actually having. We want to look at the new medications that have been introduced to them. We want to look for any drug interactions that might have occurred with the medications they are on. And it is always important to have a list of the drugs they are taking. We go ahead and look for the past medical history. We look for any medical and surgical conditions that this patient might be having. For example, in our case that we have just presented, this patient of ours is a newly diagnosed HIV patient. Okay, so that is a very key history. Then we want to look for the last oral and output, the last input and output. We want to know, because we are aware that hypoglycemia could also lead to altered mentation. Likewise, still in hyperglycemia, it could occur, okay? Or dehydration because of excess output. So all those things could help us lead to what is actually causing a problem. Then we want to look for the events around the condition, and this calls in for a focused assessment or the history, focused history from the patient's attendants, looking for any alcohol abuse. And this, we use an acronym as pre-hospital as AAO TIPS, okay? A standing for alcohol use or intoxication. Find out whether this person is abusing alcohol. Do they have epilepsy, or have they had any seizure, okay, before? Do they have electrolyte imbalance? Then we move on to insulin. These are insulin problems. For example, hypo and hyperglycemia. It could also be because of that the patient is having altered mentation. Have they taken a drug in overdose? For example, maybe they have taken diazepam in an overdose. Those drugs tend to depress our oxygenation to the brain, so as leading to altered mental status. And find out whether this patient has been treated for kidney failure before, because uremia is also another cause of maybe altered mental status. Find out whether they have a head injury, okay, in cases of trauma, or maybe. So the T here stands for trauma and temperature problems, hypothermia and the trauma, to the head injury. Then we move on to the infections, which possibly could persist with a fever, and those could also make us think of meningitis, things that could affect the brain. Okay. Then ask about any history about psychiatric problems in the family background. If it is psychiatric, then possibly someone has a delirium. Okay. Then ask if they have been exposed to a poison. For example, maybe if you find the clues around, possibly it could be a poison that could have altered our status. Then the last S stands in for the stroke and shock. There is a way we can also assess to find out whether our patient has a stroke, and we see whether it is the leading cause for the altered mental status. As you do all those, you are actually planning to transfer this patient. Okay. We do them very fast because we have to move in time. So you arrange for transport, and this is rapid transport because altered mental status is considered to be an emergency. So rapid transport to a nearest appropriate facility, and we would want a facility that is able to actually run investigations like CSF analysis, run a CT scan. They could do an ultrasound scan. Okay, so you look for that facility. Okay, and this is done through the dispatch center. So we always communicate back to the dispatch to liaise with the hospital that is actually going to receive. Okay, and we always give them information so that we get to the hospital when they are aware that we are coming, and we follow ICEBA. We give an identification of I myself and the patient. I tell them I'm bringing a patient, so and so. I tell them about what is happening to the patient at that moment. For example, in our case, this patient is having altered mental status. Okay. Then I give them a little background of what actually might have led to the problem. For example, now in this case, our patient was a newly diagnosed ISS and possibly massively wasted. All the events that I have found up there in my sample history, I could possibly note them down and give them in my report. I still give them all the assessment that I have done, including the Glasgow Coma scale findings in my finding up in the assessment. I will end by asking these people for, or maybe recommending what I might need when I get to them. Okay, what I might need when I get to them. The reason as to why I'm actually moving to their facility. Okay, so as we are moving in the ambulance, we always want to continue with continuous monitoring. We never leave this person alone. Okay, so we always have to proceed with whatever we have done earlier, and we emphasize it. For example, the airway has to be completely managed and continuously assessed. Okay, the breathing, we know that we give oxygen. We find out, has the oxygen changed our SpO2 or it has not? And if it has not, what next has to be done? All that is done while we are moving. Then we go ahead and look for the parameters in saturation. We have to look for any changes and whatever wasn't done before. Then we proceed with the Glasgow Coma changes. The levels of orientation might keep changing as you are traveling. So we have to keep checking our patient to find out how they are doing. Not leaving out the vital signs. We all know the vital signs: respiratory rate, blood pressure, saturation, temperature, and the blood glucose in case it is indicated. Okay. Please don't forget to document everything that you do in pre-hospital, because that is what will communicate to the people who are receiving that you actually did it. Anything that is done and not documented is as good as nothing done. Okay, so always hand over your patient following the iceberg, like we did in slide 11, when you have arrived at the facility, because you will now give it to them physically. Tell them your name, the name of the patient, okay? All those things like we did in slide 11, okay? With that, I would like to thank you for listening to me. That is what we have for pre-hospital.
Thank you so much, Mr. Ansu Garemon. Next on our program, we're going to listen to Ms. Halimia. She'll be talking about emergency nursing care for patients with altered mental status. Halimia, you're welcome.
Thank you. Okay, so I'm going to handle the nursing management of a patient with altered mental status. So here we are going to look at our priorities. You find that when you get to interact with patients, one way that you can easily come up with a plan of managing your patient, we normally use the mnemonic ADPI. So here you move from addressing your patient, you come up with the subjective and objective data, and then the diagnosis, the nursing diagnosis, where we can have an actual diagnosis, looking at the ongoing disease, and then a risk diagnosis. And then I formulate a plan or goal of care. Then you come up with interventions, and remember this is a multidisciplinary kind of management. Then you look at the interventions that you're going to do in order to work on the diagnosis or achieve the plan that you've made. And then with each intervention, it must have a rationale, and this rationale has to be scientific. And then you evaluate your goal. Was your goal achieved? Why didn't you achieve it in case the goal was not met? So here you focus on the assessment to identify your cause, come up with the interventions, and stabilize this patient, treat the cause, and provide a safe and supportive environment for this patient. So our first nursing diagnosis that we'll look at, this is how a care plan would look like once you draw one. So you'd have the assessment, nursing diagnosis, your goal, plan, or desired outcomes, the intervention, and each intervention must have a rationale. Why are you doing it? You don't want a situation where we find you administering paracetamol and your reason is the doctor has prescribed it. There must be a reason as to why you're administering it. And then an evaluation such that you review your goals or your plans of care. So in assessment for this specific nursing diagnosis, our subjective data from our history, we had fevers. Then the objective would be us getting the temperature, which was the 38 degrees, skin pitch less than return of greater than 3 seconds, and then dry mucous membranes. This one that symbolize dehydration. But you find that in your nursing care plan, we don't expect to find terms like dehydration, malaria, altered mental state. Those are not terms that are supposed to be used in the nursing care plan. So in the nursing care plan, you specifically look at your findings. What was that finding that drew you to say that it's dehydration? Then seizures can also be part of the objective data. So the nursing diagnosis here is the hypothermia related to inflammation, evidenced by that body temperature of 38. You can also put the skin pinch greater than 3 seconds, and then the dry mucous membranes. So you find that this is an actual diagnosis since it has 3 parts. We have the problem, which is the hypothermia, then the cause, which is the inflammation, and then the sign and symptom, or which subject has the evidence being our temperature. So your goal would be to, the patient would maintain a body temperature between a normal range, like 36.5 to 37.4 in 1 hour. So remember, as you're making or formulating your goals, they have to be smart, specific, measurable, time-bound, attainable, realistic. So you have to ensure that all those parameters are there as you're formulating your plan. So among the things that we would do for this patient, since they diagnosed that it's most likely we are having what? Meningitis, which is called from the fungal origin. So the plan was to administer antifungals as prescribed. So in this case, we had the fluconazole and then the flucytosine to be administered. So the rationale is that you're trying to treat the underlying cause. So you find that when you're managing hyperthermia, if you don't treat the underlying cause, you're not doing much for this patient. The temperatures will continue increasing compared to when you're managing just a fever. So that means you'd have to treat the underlying cause. So in this case, if you put the specific antifungal like flucytosine, your rationale has to be scientific, like we said. So in this case, you'd say that the flucytosine is converted to the 5-fluorouracil, which mimics the nucleic acids in the what? In the fungi, and inhibits the process of what? Protein synthesis in these what? Fungi, causing their death. Then another intention is to administer paracetamol as prescribed. But remember, as you're administering medications, you have to follow the 7 rights of drug administration. So much as it has been prescribed, if the doctor has prescribed and you're seeing, maybe they've prescribed 2 grams of paracetamol, you don't just administer, you have to ensure that it meets the 7 rights. And among them, we have a right dose. So as a nurse, you have to be empowered and know what are the right dose ranges that are supposed to be administered for specific drugs. Or if you don't know, please inquire, because at times you find a patient or the caretaker will ask you, why are we giving this paracetamol? And your answer can't be, it's because it has been prescribed. You have to give a genuine reason. So the paracetamol would inhibit, it does mainly 2 roles. It centrally acts, whereby it lowers the hypothalamic set point. And in this case, it helps to reduce the body temperature, and also inhibits the COX-3, which inhibits the production of prostaglandin, specifically E2, that reduces the reduces the sensitivity of the nerve endings. Then you also perform tepid sponging for this patient. So you find that in most of our cases, we rarely actually have the tepid sponge itself. So we usually improvise with a cloth. So in this case, you get a cloth with warm water, and then you pass it over the patient. So in cases where you're overwhelmed, you find that in most of our cases, the ratio of a nurse to the patient is about 1 to 11,000. So you can teach the caretakers to help you out. And in this case, they keep wiping the body of the patient with the warm water. And as they are doing the tepid sponging, they should leave some water on the body. So this works through conduction and evaporation. And in conduction, the body transfers this heat to the cloth, which is being wiped, and the environment. And through evaporation, we have opening of the pores, vasodilation that promotes the heat loss. Then you also have to continue reassessing your patient. You don't just administer your paracetamol, do the tepid sponging and stop at there. So you have to continue reassessing the patient. You monitor these vitals such that they enable you to evaluate whether your interventions have actually worked. And if they've not, then you come up with other interventions. So in this case, our evaluation would be the patient maintained a body temperature between 36.5 to 37.4 in 1 hour. That is if it's achieved. If it's not, please don't lie. Clearly say that it wasn't achieved and indicate the temperature that you ended up getting, and then generate another care plan for that specific temperature. My slide's paused. Okay. Okay, so another diagnosis that would have in a patient with an altered mental state would have a risk for falls related to altered neurologic function. So you find that in this case, some of our data, we had a low GCS, of which we said much as it was a 13/15, it can always deteriorate at any time, so you keep reassessing. So our goal will be that the patient remains free from falls within the next 8 hours. So these are 8 hours considering the hours that you're working in your shift. If it's 12 hours, you may put 12 hours. So among them, you assess muscle strength. So in this case, if the patient is weak, that means they are more likely to fall. So decreased strength can alter coordination and balance in such patients. Then you use the Morse fall scale to identify the risk factors. So you find this scale, it has about 6 parameters that help you to identify or grade how much of a risk this patient is at falling. So you find that if the score is 0, then there is no risk at all. If it's greater than 45, it's a high risk. So you look at things like, do they have a history of falling? So maybe from the history that you've obtained, they've told you this patient just collapsed or this patient is weak. You look at those things. Are they having heparin? What IVs on them? So these can cause risks. Then you should always ensure that your rails are up, and this one prevents patients from rolling out of the bed. In some settings, better settings, you'll find that patients who are at a risk are always provided with the wristbands, such in that whenever any health worker within the facility, when the moment they see such a wristband, they're able to tell that this patient has a risk of falling. Then I also keep the bed in the lowest position, so instead of raising it up. So you only raise it when you're performing procedures. We don't expect to find you bending towards the patient, in this case, when you're performing procedure. Then you also have another nursing diagnosis would be anxiety related to change in the health status, change in the environment, expressed concern or worry about illness and the hospitalization. So in this case, we've had a situation where this is now a newly diagnosed ISS. So they've just been told you have HIV. They've been admitted, it's the first admission. So you expect that the patient, the caretakers themselves are anxious about this new event. So in your poll, you plan that the patient will experience decreased anxiety, can be within 2 hours, depending, as long as the patient is now stabilized. So your interventions, you can encourage them to express their concerns. So you allow them to ask questions. You know, this gives them an opportunity to vent out their feelings, get any kind of information that they would like to know to reduce the anxiety. You also encourage the next of kin or the caretakers to stay or visit whenever possible. And this allows them to support this patient, in that the patient gets to know that there are people who are there to care for them. Encourage involvement in care and decision making, and this is where now patient-centered care comes in. So you find that as you're making those clinical decisions, we have to give you paracetamol, we have to do these tests. You involve these patients as long as they are awake. You involve the caretakers if they're the next of kin for patients who have like very low GCS, and this enhances collaboration. Then you also teach about disease progress, and then this provides relevant information, relieving the anxiety. It would not make sense, patients are seeing you moving around, this nurse is busy touching here and there, and they don't know what is happening, they don't know what diagnosis the patient is having. So always provide information as long as the patient has okayed it. But there are cases, of course, where the patient may not be able to okay. So you give them some crucial information such that they know something. It's on, eh? Okay, so another diagnosis, sorry about that. We had some technical issue. Another one would be acute confusion related to inflammation or meningeal irritation and cerebral edema, evidenced by disorientation in place and time. Some of the other things that you can also evidence would be the GCS being low hallucinations, then the agitations. So in our settings, you may not always get an ICP measurement first. So as a nurse, you have to know some of the signs that would show us whether we have elevated ICP or not. So for you to have elevated ICP, the intracranial pressure, you can look at having the Cushing's triad, where you would have hypertension in that patient. They have irregular breathing. They have bradycardias. If they are awake, they are nauseated, they are vomiting, altered mental state. So such things, you can be able to tell that probably my ICP has increased. So your plan that the patient would regain normal reality, orientation, and level of consciousness in 3 hours. So this depends on, of course, which parameter in your GCS is mainly affected. So in our case, we had mainly the verbal, whereby they were disoriented. So in this case, some of the things that you can do is the reorienting the patient. If the patient does not know where they are, tell them we are at the hospital, we are maybe in a Arua Regional Referral Hospital, and it's maybe daytime, it's 12 midday like that. So you reorient them, and this promotes cognitive function. You monitor their RBS. When you have low blood sugars, that means that the brain would have limited energy sources, and that one, you end up with impaired brain function. And then hyperglycemia would result in damaging of the blood vessels. So you want to keep monitoring these blood sugars. If they are low, give that dextrose D50%, give them what to eat in case they are not so low. Then I administer oxygen as prescribed, but remember I said you consider the rights of administration. In this case, it's to help with the cellular respiration for the brain to be able to form the ATP and also carry out its functions. Then you do pain management as indicated. If remember with worsening pain, at times you can ask a patient if they're in so much pain, you end up getting wrong answers or they will not respond to you again. So you find that when the pain is really much, it causes neuroinflammation, which consumes the working memory. So the patient may not even be able to remember their name. They cannot remember things at hand, and their attention would be limited. And then the other things that you would look at also, administering the anticonvulsants in this patient. Like if, for instance, they've already reported they have seizures, you may want to give it prophylactically. So some of the drugs that you can use, we can have the GABA enhancing drugs, like the diazepam, which is more common, the phenobarbital, and these ones act like they enhance the GABA activity, of which the gamma aminobutyric acid acts as a brake to like regulate the functions of the brain. So if it's too much, it causes what? A pause in it. So you give such drugs. We also have the glutamate, whereby this is an excitatory enzyme or neurotransmitter within the brain. So some of the drugs that can be used would be like the perampanel, and these ones help with inhibiting the glutamate that would cause more an increased brain activity that would result in the seizures. Then in other settings whereby things are a bit modern, you may find drugs like the Keppra, and these ones, you have to ensure that you do timely drug administration. Yeah, so that is mainly it regarding the altered mental state. But some of the other things that you look at, remember, you're managing this patient as a whole. Don't just focus in one aspect. We do holistic care. So this being a presentation on the altered mental state, we mainly focused on that, but you should not forget the other aspects of of the patient as you're managing them. Yes, so thank you for listening.
Thank you so much, Ms. Halima, for that presentation. Next on our program We are going to be listening from Professor David Mayer. Professor, are you on?
Yes, I'm on. Can you hear me?
Yes, please. You can hear you loudly. Prof, you are welcome, and we are eager to listen to you. Thank you.
Thank you, and I hope I will not disappoint you. Firstly, by apologizing for not having slides. I just did not get around to making them, but I think the previous presenters have done an excellent job of highlighting some of the things that I would point out. And I think we also need to work in the context or discuss this in the context of a patient for whom we have a diagnosis, right? But I think just following up on, just the selected causes of altered mental status and assuming that you are the one who is present in the emergency department, or even at the time that a patient is sent to the ward. I think what are those disease processes that you might consider in a patient who has altered mental status? So first, I think it's key, and although this was not particularly in the context of the patient that was presented, altered mental status, as has been highlighted, can be associated with hypoglycemia. And so the key thing here is obviously being able to measure the level of glucose. Some people will go on to measure the hemoglobin A1C, but I think broadly, if a patient turns out to have hypoglycemia, then the key thing is to be able to quickly give them dextrose. Sometimes you do not know, and you are not in a position, and I know this happens in many of our emergency departments, that the strips have run out, or they are not, the glucometer is not available, is locked up, which is a shame. But I think at that point, you'd rather err on the side of giving that individual 50% dextrose. And some people indicate that, an ampule, I think this is about 20 mils, 10 or 20 mils of dextrose 50 only contains 100 calories. And so that's not really feeding the patient, but neither is it a huge problem if they are hyperglycemic, but you'd rather err on the side of giving them the dextrose. Obviously, as the first thing is to make sure that you can measure the level of glucose. The second aspect, I think, which one of the presenters touched on, was opioid overdose. Maybe depending obviously on where you work, might not be on top of your list for a possible disease process, but certainly in places, whether that's urban areas, where opioid overdosing might be a possibility, using naloxone you should have naloxone on your emergency tray. It's important to note that naloxone has a short half-life, and so you might consider using longer acting opioids like methadone, particularly if you're keeping the patient for a while. The other disease process is, agitated withdrawal states. And for these, patients, again, and I think this has been highlighted already, just in terms of the description of how they might show up, it's important that you consider supportive care and sedation. And so, if you do not have drugs to sedate these patients, there will obviously be chaos in your emergency room. it's important to remember that excited delirium is a true medical emergency and poses high mortality. And so that has to be addressed with caution, but it also has to be addressed quickly, because that individual might be a danger to themselves and to the rest of the healthcare workers, as well as the other patients in the emergency room. The other important disease process to think about is patients who show up with dehydration or hypovolemia. I think one of the presenters highlighted this as well. This is something that you will typically be able to identify as part of your clinical assessment. And, the natural thing is to have fluid resuscitation. And this could also be, in the context of infections, because a patient might show up with what is suggestive of sepsis and associated altered mental status. As far as other aspects of infection are concerned, and I think those have been touched on very well, this patient required lumbar puncture. I think it is one of those things after you have assessed the patient. So it requires that you have clarity in terms of your clinical assessment and that you're able to make the decision around the next steps. And so for patients who obviously have signs, neurological signs suggestive of meningeal irritation or encephalitis, you want to be clear on what the next steps are before you even think of imaging or such interventions. You would want, as in the case of this patient that we discussed, that you're able to do, you have the knowledge, you have the ability to perform lumbar puncture. And of course, in the context of this particular patient who had advanced HIV disease and had a CD4 with a CD4 less than 200, had what was suggestive of meningeal irritation, the lumbar puncture becomes pretty clear, and that's something that you have to do. So lumbar punctures in meningitis, and particularly for cryptococcal meningitis, can not just be diagnostic, but are certainly therapeutic as well. I think somebody talked about, raised intracranial pressure, and knowing that that's really an emergency and it needs to be dealt with in the emergency department, and not have the patient sent off to the ward as part of their disposition. So it's important that we become aware of who needs a lumbar puncture, in which type of patient can you wait, but there are also the pre-lumbar puncture assessments. For instance, screening for opportunistic infections, and particularly for this patient, obviously I think doing the serum cryptococcal antigen test was important in guiding the next steps around the interventions of a lumbar puncture. The other aspect is hypo or hyperthermia. Again, depending on the context in which you find yourself, we might not necessarily have a lot of patients presenting with hypo or hyperthermia in our context, but as the condition warrants, you would either have the ability to warm or cool the patient as needed. Of course, some people might present with hyperpyrexia, and so you might have to have some aspects of cooling. And I think the previous presenter touched on some of these as well. In terms of the disease process around overdose, and that could be overdosing on anything, supportive care and antidotes, if you are able from your history to establish what exactly the patient overdosed on. And I think some of this has been touched on already as part of the history and establishing, the pre-hospital events, that pre-hospitalization events. But thinking through redoxing or other antidotes like atropine, I think those are things that you need to think about as well. There are patients who might show up as part of the altered mental status with hypertensive encephalopathy. And again, determining that, the ability to check the blood pressure is obviously paramount. You cannot be in an emergency room and you do not have the ability to check for blood pressure. So very important that you check for the blood pressure, and once that is elevated to a point where you think this patient now has encephalopathy due to the hypertension, again, having drugs on your emergency trolley, including nitroprusside, labetalol, nicardipine, or other antihypertensive drugs is obviously key. Patients might also show up, and particularly if this is more or less elderly patient, has been unwell, not with a lot of oral intake, they might show up as part of that disease process with hyponatremia. And so thinking through the ability, obviously, to be able to quickly identify, and this, I think the only reliable ways to be able to measure the electrolyte levels. So the ability of an emergency department to run certain quick evaluations like electrolytes, I think is obviously very important as well. So if an individual is found to have hyponatremia, first of all, I think it's important that you match the acuity of the presenting symptoms with your treatment. So if there's been some evidence of low sodium, if you have some prior labs available, and there's just been low sodium over a couple of weeks, you do not need to correct that sodium immediately, especially if there are minimal symptoms. However, if a patient shows up with seizures and altered mental status at the time, and it's clear from the history that there's an event that has led to the hyponatremia, then the use of hypertonic saline becomes important. So beware of rapid correction, of the hyponatremia, which, as we know, might cause central pontine myelinolysis. The last two that I will touch on are CNS lesions that cause vasogenic edema. And again, this sort of leads back to the ability, in the emergency department to potentially be able to quickly have a CT scan, because again, this might be a little bit difficult to evaluate, as you can't just use an ophthalmoscope, to do fundoscopy. There might be a need to quickly have imaging done. And so in patients who obviously have CNS lesions that are obvious and are causing vasogenic edema, typically you want to be able to use glucocorticoids to manage that. The last one, again, partly based on the history that you're able to obtain, but also from your physical examination of a patient who's been brought in with altered mental status and has a clear odor or scent of alcohol around them. Again, Wernicke's encephalopathy becomes a disease process that you need to think about in your diagnostic pathway. And typically here we would use thiamine to manage those patients. So I hope I have touched on a number of these, and again, you know, some of these were already discussed by the previous presenters as well. I think a few key things, again, it's important that one can recognize subtle changes in behavior. And, you know, this is based on your quick history taking in the emergency department as you talk to, you know, individuals who have been witnesses. It's important that you listen to what they're telling you. Sometimes there's a failure to recognize altered mental status, especially delirium, as a symptom of serious medical illness. So thinking, what do they say? Think about the thing behind the thing. Why a patient is showing up with delirium, think through what the possibilities are. And I think one of the presenters highlighted a really neat mnemonic that you can use to think through that. It's important that you should not fail to look for and treat easily remediable causes. And again, this comes down to the context in which you work. In the context of the patient who was presented, you know, you have to be able to think about what the possibilities are. Yeah, I think those are the quick comments that I wanted to make, and I do hope that it will help us to just think better as clinicians, particularly in approaching patients who have altered mental status. Thank you.
Okay, thank you so much, Prof, for that wonderful presentation. I think we're going to have two to three people ask a few questions, and we'll get to answer them. From the audience, if anyone has a question for Professor Meyer, please, and raise your hand and he responds to your question. And also, Dr. Isaac, if you have any important question that was asked in the audience that you would like to answer openly, please can also ably do that. Any question from the audience? Meanwhile, we're also having a post-test, a post-session poll, which is ongoing. It's displayed there for you. We have number 1 there, which is saying, from the history and parameter survey, what is the most eminent emergent in this patient? And the answer was? Okay. Then we have the second one, based on the above information, what are your management options for this patient? The options are there. Then 3, what was the CSF finding? What are the CSF findings in Burkitt meningitis? Then 4, what is the different management option for this patient? And that was our last poll question. Okay.
Can I, oh, sorry, there's just one comment maybe to, yeah, I think somebody asked, I think it's, who asked? Anyway, somebody asked about, yeah, John Magamba, avoiding a lumbar puncture if you know or suspect increased intracranial pressure. So again, I think one of the key things to remember about patients with cryptococcal meningitis is that they have uniformly elevated intracranial pressure just because of the fluid, the pathogenesis of cryptococcal meningitis, where the fungus sits and blocks the arachnoid villi where CSF fluid reabsorption would take place. So there's no obvious shift in the, midline shift, as it were. And so in those types of patients, you've done a serum CRAG that's positive, you might want to do a lumbar puncture because, as I said, it is not just diagnostic, but will also be therapeutic. Of course, you need to have excluded any focality, and so a good, CNS exam is very important, particularly in patients who have altered mental states. So if you've done a serum CRAG, it's positive, you know that this patient has, advanced HIV disease. Yeah, I would probably, and you have checked and the pupils are equal, well, reactive. There's no focality in terms of weakness, hemiplegia. I would be comfortable to do a lumbar puncture, even if you are not able to image the brain at the time. Thank you.
Okay, thank you. Seeing a hand from, first is Derek Semambo. Please, Derek, what's your question?
Thank you so much, dear experts, for the great session. My question is, I would like to get some clarity on the use of D50, bolus D50 in cases of hypoglycemia. Just your view, Professor. I don't know what's your take on it. Thank you.
So I think the quick answer to that, and obviously this depends on what you have available. If I recall correctly, most D50 in our setting, most will come in 50 ml bottles, right? And so I think, if you have established that, well, if you have not established that there's hypoglycemia, again, probably 20 mils of that D50 should be sufficient as a start in the emergency room. I know there's options of using the mils per kilogram, but sometimes you do not have you don't have the patient's weight, and so I would say 20 to 30 mils for me as a start would be a good option.
Okay, any other question? I saw someone there was who? Please feel free to ask. We give an allowance of 3 people. Someone will be below. Yes, Dr. Isaac, are you on? Dr. Isaac Gasingla.
Yes, I'm on.
Yeah, please, would love to hear from you lastly about any questions that you asked in the audience that you would like to highlight more on verbal, and maybe we get to understand them better. Some people might have missed them. The questions that were asked in the audience.
Some of the questions I think were the induction treatment regimens for cryptococcal meningitis, and there are a number of treatment regimens for the induction phase of cryptococcal meningitis, and these are based on what antifungals you'll have available at your facility.
Yeah, that's all. Okay, I think we have reached an end of
Recommended. That is oral. Come again. Currently, 3 antifungal drugs are recommended for treatment. That includes oral fluconazole, oral flucytosine, and IV amphotericin. So the best regimen is really, if you have like liposomal amphotericin available in your facility, is to use the single high dose amphotericin regimen, where you give just 1 dose at 10 milligrams per kg of liposomal amphotericin and then 2 weeks of fluconazole and flucytosine. This regimen has similar efficacy to all other regimens. It also has less toxicity. You're giving the amphotericin once. It is also easier for the team in the facility to give, because you don't have to give daily doses of amphotericin. You just give it once. So it is good and feasible. And it can also allow you give you an opportunity to be able to discharge the patient faster. Traditionally, patients with cryptococcal meningitis were treated inpatient for 2 weeks, but this regimen gives you a leeway to discharge the patient earlier if they are doing well. The other question is to do with should we do LPs for patients who we suspect raised intracranial pressure? And I think in a patient with cryptococcal meningitis, doing an LP is standard part of management to manage raised intracranial pressure. And if you have assessed the patient well and excluded any contraindications of doing the LP, you should please go ahead to do an LP. Raised intracranial pressure is one of the poor prognostic factors of poor outcomes in patients with cryptomeningitis. So for patients who have any signs or symptoms of raised intracranial pressure, please do not fear doing the LP if it is safe to be done. The other question was how do you measure the opening pressure? So technically, we would use a manometers, but these are not very available in most of our facilities, and you may struggle to get one outside the research setting. So technically, you can determine that depending on the rate of flow of CSF from the needle while doing the LP, and usually. And this is really abstract, but it really does work by counting the droplets. So if you're doing that LP and you get more than 40 drops of CSF in a minute, you consider that patient to have raised intracranial pressure, and you can then use that as a guide to drain off slightly more CSF than you would ideally do. I think that's it from the chat. Don't know if I've missed any other questions. Over to you, Chair.
Okay, thank you so much, Doctor, and thank you, our listeners. I think we have come to the closure of this session for today. Thank you so much for tuning in, and I hope we have learned something as a team. Okay, so we had around 4 poll questions, and we are going to, in a few minutes, just run through and you get the answers. So for question 1, the correct answer was hypoxia and severe respiratory distress. For question 2, the correct answer was intravenous paracetamol 1 gram with oxygen therapy. For question 3, it was turbid glucose or less than 2.2 millimoles per liter with the white cell blood count greater than 1,000 copies in a microliter. And for question 4, the correct answer was a single high dose liposomal amphotericin B 10 milligrams per kg, followed by flucytosine 100 milligrams per kg once a day, and fluconazole 1,200 milligrams once a day for 2 weeks. I think that's it. Thank you so much for tuning in. We'll see you again next Friday for our next video. Sorry? Hey, please put on your videos and we take some screenshots. Please. I don't have the list here, that's why. I don't know. Let's connect the videos, please.
One question was not answered.
Let's do the videos. Benjamin Ochuka, I'm not seeing your video. Dr. Isaac, you logged out. You can also do some video with screenshots. Okay.
I'm seeing most of them are there. Who is there? Wasn't Sadiq? I'm not seeing your video. Sadiq, Natalia.
Oh, yes, send it on.
Yes.